doesn't know, I'm Councillor Anne Hannah. I'm the councillor for Lower Braes and I'm the Labour representative on the IJB. Can I assume that everybody else who's here and on the screen knows one another, or do we want to do introductions? Okay, is anybody not clear about who's who? Okay. So first matter on the agenda then is apologies. So you said you had...
Yep, that's right, Councillor Hannah. We've received apologies from Gillian Morton and Andrew Murray.
And someone said Patricia as well.
Yeah, and Patricia Cassidy too.
Right. Okay. Next item on the agenda then is any declarations of interest? No, none? Okay. The third item on the agenda is the minute of the Clinical Care Governance Committee on the 20th of May. Item number 3, page 4. First, can we agree that as a correct minute, or does anybody want to make any amendments to it? Correct minute. Right, are there any matters arising then? Anyone want to raise anything from the minutes?
I don't think there's any matters arising, particularly from the note of the meeting. We've got an action log that picks up any sort of ongoing actions as well, and then we've got the sort of agenda items that are some of those are standing, which provide updates.
So we will go on then to item 4 on the agenda, which is the action log. There's only a couple of items on the action log. Does anyone want to just talk to these? Any issues arising from it?
Just in relation to the MAT standards, which is the remaining open action, there's a significant amount of work being done locally around that area of work, and Martin may want to sort of add to that, and an update will be taken into the senior leadership team. Martin, if you would want to add anything.
Yeah, I was just about to say exactly what you've said there. We've recently done a self-assessment around progress to the MAT standards, which has gone into government, and we are in the process of completing a wider self-assessment around the operation of the ADP. As you'll know, we're in the process also of setting up a workshop specifically for elected members. We're planning to run that probably towards the end of September. And at that point, we'll go through some of the information that we've pulled together as part of that self-assessment. Initial feedback around our progress to the MAT standards is that we seem to be on track. The big problem areas for us are around that one-day access to medicine-assisted treatment, and that's primarily down to, I guess, us struggling to find sufficient consultant capacity for prescribing. We think that's probably going to be the major problem nationally. So I don't think it's just going to affect us in Falkirk and Forth Valley. Consultants are very hard to come by, as are kind of most staff across health and social care at the moment. So that's probably going to be our particular challenge going forward. But we continue to make really good progress. I chair a MAT standards subgroup of the ADP, and we meet monthly just to monitor our progress. So we can bring a much deeper update to any future clinical care governance committee, but I'm conscious, I think, that we covered MAT standards maybe 2-3 meetings ago. So I'm not sure if you would maybe just want an annual update on our progress. It initially started as a get the standards in place within 12 months, but then I think there was a realisation from government that actually was going to take some time. So they extended that to 5 years. So we're a year in, and we've still got another 4 years of progress to make. Hopefully that gives you a bit of an overview, but as I said, I'm happy to bring something back in more detail to a future committee.
I think that would be quite useful because, as you know, I'm kind of new to this, and if if people don't bring it to the committee, I'll just come back to you and say, can I have a briefing, please? As you've already discovered, whenever something comes up, I want another briefing. I'm hoping the time will come when I know what I'm talking about. I mean, I'm concerned about the one-day access being a problem, because clearly that is a key part of the standard. And I recognise the problem about staffing, but is there anything else that we're able to do to improve that situation? Does it have to be consultants that do it, or are there other health professionals that could do it?
I think the difficulty is that what they're asking for is a significant shift. So the ask in the MAT standards is that you get same-day prescribing effectively. Historically, what we've tried to do is pull people into treatment initially, and tried to do that really quickly. Now we have struggled to get people into the treatment system within one day, and quite often a lot of services have waiting lists. And so the challenge is trying to find a prescribing service that can get somebody and wrap around all that support to actually make sure what you're prescribing them is the right thing. So it's a bit more than somebody turning up and just walking away with a prescription. It has to be something that's right for them, which will involve a much fuller assessment. And I think that's why we're looking at consultants really leading on that, because it is going to be really complex prescribing. Historically, the way services have progressed with prescribing is people have come in, they've had a bit of support, they've had some quite intensive work done with them to determine their history, to determine their levels of tolerance and that kind of thing. And they've been monitored, perhaps drug tested for some time, so that clinicians know exactly what they're going to be prescribing them. This is a real shift in that approach. So it's taken some time to plan, but also we need to consider, I guess, much wider than just somebody that writes a prescription. It's all the support that goes with that. I suppose you'll probably know it's quite dangerous to write somebody a prescription without doing all that work, because they could go away and continue to use, and then that would actually increase their drug-related deaths as opposed to reduce them. So it would have the opposite effect from what we're trying to achieve. So it is just trying to plan that holistic package of support for people that can actually get to the real crux of some of their issues prior to prescribing, and getting the prescription in place for the same day. Which is why I think there was that recognition that actually it's not something you can bring in really quickly, because there are so many facets that you need to explore, and you need to bring together a whole package of support for people. So we have elements of that are in train just now, and we do have quite good access to services in Falkirk and Forth Valley at the moment. We don't have the 6-month waiting list that we've seen in some other areas. So I think we're in a good place to progress, but we still have quite a bit of work.
Welcome to Stephen and Gordon, who've now joined us. We're just at agenda item 4 at the moment. The action.
Apologies, Chair. Broadband connection this morning. It's like waiting for a bus.
I think I had some challenges as well, so I very much understand. Okay, as I say, we're just looking at the MAT standards and the issues there. I think maybe I could ask a lot more questions, but we'll maybe leave that to the briefing rather than clogging up this meeting with it. Unless there's anything else on the action log. No. We'll move on to agenda item 4, the Trauma Champions update, and this I think is Julia's report. Do you want to speak to that?
Thanks very much, Councillor Hannah. Yeah, thanks very much for timing the agenda today, folks. It's much appreciated, and I think you've got the paper that's been submitted, so probably have had a chance to kind of have a look at that ahead of the meeting, but I'll try to be brief, which is not my strong point, Councillor Hannah, so do throw something at the screen if I start to talk too long.
I like detail.
Absolutely. Honestly, don't be afraid to shout though, because I could talk forever about this and just bore everybody, so please do let me know. So yeah, I was asked today to come and have a bit of a brief round about the Trauma Champions, which is work that's kind of been in its inception probably over the last year, but it's been growing nationally for the last probably couple of years, and a lot of attention and momentum has kind of grown behind that. So I'm going to try and run through a briefing as kind of as briefly as I can and allow time for some discussion and questions, so that you know, people can take it away, and I'm absolutely more than happy to be contacted out with the meeting as well if anybody wants a sort of deeper dive into that. So just kind of starting off with a bit of the background summary really. The kind of ambition that was set by the Scottish Government, I've got in 1.2 there in the paper, and that quote kind of sort of summarises exactly what that ambition is quite nicely. So, a trauma-informed and responsive nation and workforce that's capable of recognising where people are affected by trauma and adversity, that is able to respond in ways that prevent further harm and support recovery and can address inequalities and improve life chances. So a very ambitious you know, set out agenda from the government around about how we tackle this and how we support our workforces. So the ambition is that everybody within the Scottish workforce receives training and support to understand the key role that they have to play, and the skills that they need in terms of delivering that work. And that falls into policy development and systems and processes and operational working right across services too. Moving into the background a little bit, I guess the commitment from the Scottish Government fundamentally is that there is a reduction and a prevention, really, an agenda to prevent adverse childhood experiences, and to support the resilience and recovery of all children and adults affected by psychological trauma. And it's the ambition of Scottish Government and key partners and COSLA to have a trauma-informed workforce that are capable of recognising where people are affected by trauma and adversity, and that are able to respond in ways that prevent further harm, support recovery, address inequalities, improve life chances. So back in 2018, when this sort of, well, this conversation's decades long, of course, but more attention was brought to this with the inception of the National Trauma Training Programme, which is led by NES and absolutely is supported by a range of organisations and linked to the government. And they've really been pivotal in terms of starting this work and driving it forward, and looked at lots of training resources and implementation for all parts of community planning partnerships and councils and NHS. So in terms of like staff training and development and well-being are absolutely key components of any organisation's journey to becoming trauma informed. In fact, it's absolutely the fundamental. Equally important, though, are the processes and policies and environments across all of our services and organisations and multi-agency systems that can enable and maintain the ambition of a truly trauma-informed service. I want to kind of just bring us down to the chart that's kind of closer into T.6 there, if I can. And some of you who I know that we've kind of had some conversations about this before, so you may well have seen this, but the chart below is called the trauma lens tool. And I know that from Suzanne told me the pictures don't always go well in these papers, but I actually feel like it's really important that there's a visual around about this, because it's kind of absolutely key in terms of this work that we drive forward. So the trauma lens tool is set out underneath 5 principles, which are safety, choice, collaboration, trust and empowerment. And it's very much the tangible, it's very much a sort of self-assessment. It starts as a sort of self-assessment tool across your own service to look at all areas of your service delivery, in terms of your correspondence, your reception area, how your receptionist speaks to the people that come into the building, what your assessments are like, you know, whatever service delivery that you have, it really can quite critically look at that and almost kind of build into a bit of an operational plan round about the bits that we're really getting right and probably flagshipping in many areas, and areas where you think that feels like we could do that better. Now, this kind of tool has been applied already in many different areas, and some people in the call have heard me saying this before, but I manage the community mental health services, so I'm based in Woodlands, which is over in Falkirk Community Hospital, and we've applied this tool in our building. And it's really interesting because working in this building, it's a fabulous building. It's an incredibly nice atmosphere to be in. It's very bright and airy, and actually feels like a really nice place to be. We've got good rooms, good ways of delivering. And for the most part, people that had not been in the building before, that was the reflection for service users, carers, visitors that were coming into the building. But really interestingly, previous to it being its function just now, it used to be the admission area. Before Forth Valley was open. This was the Falkirk Mental Health Admission Ward. So for many people that are still in the system or returning to the system, it was actually quite traumatic coming back into the building, because they may well have been detained within the building or had very difficult experiences that actually were really, really challenging. And coupled along with that, some simple things like we've got a really large reception area, which for us as staff members is great because it's really spacious. It's actually been particularly good during COVID because of spacing and things. But actually, the user experience has been that it's actually quite quiet. It feels quite echoey. If you're already anxious coming into a service, it can make you more anxious. So that's really helpful, because I'm not sure I would have recognised that before until we did this. And then it allows you an opportunity to kind of think, how do we do this differently then? How do we make it more friendly and open for people to come in? So it's very tangible and really helpful for services to kind of give them a bit of a look and something to kind of work on to start evaluating your service, which is really helpful. So moving on to section 4, which is a bit more about the meat in the sandwich, if you like, about the trauma champions. So there is substantial evidence that a key factor in driving and maintaining trauma-informed system change lies in trauma-informed leadership. And I guess further supporting the ambition, Scottish Government and COSLA invited all local authorities, integrated joint boards, health boards and other key community planning partners to nominate local trauma champions. And the champions will have an appropriate level of kind of seniority to help influence change. So the key part for the trauma champions is that they're responsible for overseeing, encouraging and raising awareness around trauma-informed and trauma-responsive practice across all services within the area. And the trauma champions will collaborate with others across all sectors to build on the progress that's already happening in many areas. And a couple of key principles around that is that, I guess, trauma work is designed to support existing local and national priorities. It's not about coming to a service and saying, right, let's now make you trauma informed. I think with current service demand, that's not an attractive prospect for anything, because things are incredibly pressured and busy. This is much more about a drip-feed cultural shift in terms of how we interface with the public, how we interface with people, and the way that we do that. And actually, you know, really questioning ourselves about how do we make small shifts to make that a bit more trauma informed, and how do we train our staff to make sure that they're very well aware of their requirements within that. And I think that's really, really critical, actually, and the message that should be absolutely sent to services and teams in our areas across the communities. It's not an extra, it's about what we do just now, but thinking about it and being quite critical about it. Supporting prevention and early intervention in terms of reducing barriers in services and ensuring people are able to access appropriate support as early as possible, and improving life chances for people across our communities. That fundamentally is our principle for why we do most things anyway, not just trauma-informed care. That's what we're all trying to do, and that's the ambition. So what does this mean for Falkirk? So currently within in Falkirk, we've got 3 trauma champions appointed to represent and lead the trauma-informed practice in Falkirk. So myself representing the Health and Social Care Partnership. We have Ali Walls, who is Service Manager in Justice, and Evelyn Kennedy, who many people on the call will know these guys as well. And Evelyn and Ali and I work really closely together to kind of pull together our ambitions around that, and really think about a really wide plan of how do we hit everything. We don't want it to be very health dominated or very local authority dominated. We actually want this to be about people, and it should be across the organisations. The other thing to mention is that there is a bit of funding attached to this as well, which is really attractive. So £50,000 in 21-22 and £50,000 in 22-23 has been given to local authorities, and this for us will fund a strategic post which will support the leadership and strategic development, the training work and the training framework and the policy work. And the job description at the moment is complete. Evelyn's, I can't take no credit. Evelyn's done a lot of work behind that, and we've put a little bit of work into that to make sure that it kind of meets our needs. And what we've seen across the country is that there's people have used that in different ways. Some people have used it for administration purposes. Some people have used it for actual trauma work. And I think for the most part, lots of areas have used it for more of a strategic development type role, which is related to policy and really helps us with the training framework, which we see absolutely as a priority. So that's why we've moved in that direction.
Can I ask you to pause just a second there, Julia?
Yep.
He said there was 50,000 in 21-22 and 50,000 in 22-23, but we're still just looking at a job description. So have we lost the 21-22 money? Has it been used otherwise?
No, we've got that money accumulated, Councillor Hannah. So
So
we
it's
actually,
still,
yes,
it rolls over.
Absolutely. So what we expect is that we would have a 2-year post. I should have written that in the paper actually, but what we expect is that we have a 2-year post with that money. That's certainly the ambition. And I think whilst the money came in 21-22, it was pretty late and we weren't quite sure of the caveats around about it at that time. So that's why we're kind of in the position that we're in. And actually most boards are in the same sort of situation. I've just get to that point, which I think actually the government took into account, which is why they've allowed us to roll over the money. So, so we have got that £100,000 and hopefully that gives us 2 years of this policy and strategic framework support, which is really, really good. So we've got a Forth Valley wide steering group as well, incorporating the trauma champions across Falkirk, Clackmannanshire and Stirling, Health and Social Care Partnerships, the councils and the NHS. And that's really incredibly helpful, particularly having the sort of more expert, although I work within mental health and that's absolutely my area of expertise, I'm not a trauma expert, and actually that's not, in terms of that real expert level in delivering very, very trauma specific work. But actually within the steering group, we have got that. We have that with Linda McCausland, who is our lead from health, is absolutely a specialist in trauma. She leads that service, so part of that steering group. And there is also an absolute lead for the health board, Adele McGlanaghy, who's also part of that group. And it's really, really helpful because we'll get similar people like Ali and Evelyn and myself from Stirling and Clacks, and bringing us together just allows us to share that knowledge and look at what we're doing. But undoubtedly, like many things, what we didn't want to do is not move forward because other areas of the board and the partnerships haven't moved forward. It's really key that from a Falkirk perspective, Evelyn and Ali and I were really keen just to kind of let's get moving with this and let's try our best to start drip feeding, which we have done really over the last 6 months or so. So the other bit around about that is it's a bit of a movement. So it can't happen on its own. We need doers. We need people across services to be able to, for example, with the trauma lens tool, to start taking that to services and help us to kind of drive that forward. So we've identified quite a lot of people. A really good example of that is we've got a community psychiatric nurse who kind of sits underneath me in health service, but is absolutely based with the justice service. Now she's a really key person because we know that actually within justice there's a higher prevalence of psychological trauma. So actually that's really key in terms of driving that forward. So she's a really good conduit and somebody that can really contribute to that. And we've got lots of other bodies that we're trying to bring together as well. So the evidence base, I'm not going to drill into too much because I think I'm probably preaching to the converted in many ways, but suffice to say that there is strong evidence that actually adverse childhood experiences exist for probably all of us to some degree. We all have experiences in our life that may or may not impact on how we grow as adults, and you can see the figures there that it's 1 in 7 adults reported to have 4 or more childhood adverse experiences. And I think when people think about trauma, sometimes they still think about the high-hitting level of abuse and neglect and the real high-hitting stuff. But actually, it can be really traumatic to have separated parents, to have one parent that's a substance user, to have a broken home, to have a family member who has additional needs. Lots of things do actually bring that person to that journey. And it's fair to say as well, sometimes people who have experienced really high-level, difficult trauma don't actually function really well in life as well. It's absolutely not a one-size-fits-all. It's about us in services thinking, let's be person-centred about that and be able to pick up what we need for each individual. So as I say, offline, I'm more than happy to talk about more of the evidence and more of the stuff behind trauma and what that kind of means if anybody wanted to hear more about it, but I won't drill too much into it.
Can I just push you there again? 1 in 7 adults actually seems low to me, to be honest.
Yeah, possibly, and I guess those figures are for 2019, Councillor Hannah, so you may well be correct there, and I guess that's the reported work.
The reporting, yeah.
Yeah, and I guess one of the really important things for us in terms of our inequalities agenda is that we know that prevalence in housing and in justice and in substance use, trauma's higher. We know that trauma's higher, and that allows us to kind of target those areas in terms of what that looks like and really start with that, So so Ali and I have had really good conversations about, for example, what does it feel like for people in the justice service who we know are probably have experienced trauma as a child? Do they recognise it? That's people that recognise that they've experienced trauma, I guess. Not everybody recognises that if you've grown up in a level of dysfunction that feels normal, you know, that abnormal normal. So yeah, you're absolutely right. It's probably quite conservative. In terms of the sort of learning and kind of some of the development and the training and stuff, the National Trauma Training Programme, I've got a new module just recently. There's absolutely lots and lots of resources, which I'm going to talk a little bit about in a minute, just as briefly as I can. There's a new module, and the key bit around about this is it's absolutely open to pretty much everybody that wants to learn more, everybody that wants to know more and take this to their own networks can go and do these modules pretty easily, actually. The Falkland Council Leadership Forum members were invited to attend the kind of June webinar, which again was right across services. Evelyn kind of drove that forward and sent that round to make sure that people are starting to get an awareness around about this and getting invited to the right things and aware of the training and around about what goes on. The section around about the enhanced level trauma training, this is about the Justice Service. So the Justice Service has commissioned 4 2-day enhanced level trauma training programmes for 20 participants per session and 4 train the trainers places. And that's fantastic. So Ali and Ali's service have kind of bought that in to start the ball rolling with that. And I think the really key take home from that section for me is that the train for trainers can really start to help with other parts of the organisation and other parts of the system, because it's not just specific to justice, but that's absolutely where that will start and get delivered. And that's a really, really good piece of work that's happened, actually. And that's as we speak, actually. I think the trainer for trainers was actually this week. So that's kind of moving forward, and you can see that there's competencies that they want to align with there in 4.13. So kind of moving on, I wanted to just mention one more thing before I kind of finish up. I want to draw your attention to the appendix, which is really a fantastic resource that the National Trauma Training Programme have brought together, and it kind of pulls all the resources together all into one kind of A4 page, and they pull us all together, the trauma champions across the country, and some of the feedback has led to that, because there is huge amounts of information around this, almost flooding the system, and actually for briefings like this, or elected member briefings, or going to CPPs, it's really helpful to have something quite succinct to be able to say, you know, if you want to know more, go here and have a look at this. So that appendix really gives you that. And the one thing I would kind of draw your attention to in terms of what it means for Scotland and how our ambition more about that in much more drilled down detail would be that toolkit. There's a trauma-informed practice, a toolkit for Scotland. There's a link to that on that resources page for people that want to kind of understand a little bit more and take that forward. That's as much as I was going to say, Councillor Hannah. I don't know if you want to open up to questions, or if there's anything around about that paper that anybody wants to ask more about.
I would like to ask one thing first, and then I'll open it up for questions. You mentioned elected member briefings. It seems to me that elected member. I sat yesterday at a training on keeping myself safe. You know, the security for councillors, what we should do in the light of Joe Cox, the MP Amos, and so on. And I kind of butted in saying, but you know, that should include the protection of the people that are coming to us in our surgeries. And I think that's something that's kind of missing. Okay, I totally agree. Our security is important. We need to take care of ourselves. But we also in that need to be aware, because I know I've not done a lot of surgeries yet, but I have had people come to me who clearly have suffered abuse and who clearly have some quite serious in some cases. And I think all councillors could do with a bit of that training, to be recognising, to be knowing how to deal with those. Now, how to deal with it usually is passing it on to one of you rather than us actually dealing with it. But we have to recognise it first. I've worked for years within social work, health and social care, on welfare rights, doing advice services. So I have had a lot of training on these kinds of things, but a lot of councillors haven't.
Yeah, absolutely. I think that's a really good point, actually, Councillor Hannah, and I think there's definitely room for training and support around about that. There's also something about the well-being of yourselves when you're dealing with that kind of information as well. There's a bit of psychological safety required around that, the other point you made there about people coming in and possibly having conversations that are pretty sensitive a lot of the time, I'm sure, and there's a bit of disclosure around that. Now, I guess historically, there was always, and even in my many years ago when I trained the year after Florence, even then we were told, you know, if somebody talks about trauma, you have to shut that down. Don't get into a conversation about it, because, and I understand that philosophy and that thinking, because that's about, of course, but that's about not picking the scab, if you like, because sometimes the more you talk, the worse it gets. If you don't do it in the right way, and that's certainly correct. We know that in terms of psychological safety, that is what happens. However, there is something about in the here and now, recognizing somebody's distress and having the right tools yourself to be able to say, this is how I can support you with this right now. I recognize you're talking about lots of levels of things historically, and it's good that you're ready to talk about that, but actually let's think about how we keep you safe just now, and what skills I can use to help you do that. Yeah. And that's trauma-informed practice. That's the bit about us as humans, as people, being able to interface with people in a way that actually feels safe and comfortable, and not shutting it down and invalidating people, but also not getting into something that you can't, a rabbit hole that you can't kind of get out of either. So there's a balance to be had. So I think your point's really valid about having the right level of training and accessing that for the councillors. So that's maybe something about even that resources sheet, Councillor Hannah, can be something that's helpful in terms of tapping into that. And if there's a bit more required, don't hesitate to get in touch. We'll try and put you in touch with the right bits and bobs that can help.
Yeah, I mean, I have seen some other councillors come out of their surgeries traumatised because of some of the things that they're dealing with. Yeah. I'd say I've got more experience in that front, and I'm not easily knocked off, but it's a problem for some people who've not had that kind of background. Okay, has anybody else got any other questions? Okay then, in that case, the recommendation is simply to note, isn't it?
A couple of questions.
Sorry? Oh, there are kids, sorry. Oh, right. Who came first? Roger, I haven't had a chance to welcome you to the meeting. So if you'd like to give us your question first.
Thanks. It's not really a question, it's just really a point that Julia Riley says that around 1 in 7 of people have suffered trauma, and that includes us, employees. And you know, it occurred to me fairly recently that when I was representing a staff member, the manager was saying that we're fully trauma informed employer, but the employer hadn't recognised the trauma in the staff member that was struggling. So I think that we need to recognise also here that many staff have experienced trauma, and we need to recognise, have our eyes open to that when responding to the needs of staff, particularly given the pandemic that's just hit us.
Yes.
Definitely. Can I respond to that, Councillor?
Yes,
Hannah?
certainly.
Okay, just because I think that's a really good point, and you've reminded me something I was going to say, Roger, so that's really helpful. Thank you. So when we were talking about that trauma lens tool, one of the things that really has the ability to do is really look at, from a leadership point of view, what does your supervision look like? Are there questions around about mental health and well-being, emotional safety, you know, how you cope at work, how you're interfacing with your colleagues, what kind of cases are you managing, and actually really having an open conversation and not accepting that staff just deal with that actually it's really tough, and we actually have stress in our own lives that we're trying to manage as well, and that's really difficult. And in a mental health world, when you talk to sad people all day, you do become a little bit sad yourself. It's really difficult to avoid that, and I think recognizing it actually validates how you feel, because nobody should, you know, we're not immune to any of that. And I think some of the processes you're talking about there, Roger, actually it can be really helpful to be quite critical about how do we manage our staff? What kind of open conversations do we actually have? And do we have a channel where people do feel safe to say, I'm really struggling with that, and this case is really bothering me because of that, or I've got this going on at home, so I don't feel I can cope with that. And are we being trauma informed in the way that we actually respond to that? And do we lend ourselves well as an organisation for staff to feel safe to say that out loud? And I think that's really key in terms of that, in terms of how we operationalise this and how we start to drip feed that forward. Because often when you ask the question, they've not thought to tell you until you ask. So and I think that's what you're kind of saying there, Roger. There's a bit of an acceptance that people understand we're all trauma informed, and we work in mental health, so we all understand it. Actually, that might be the case, but it doesn't mean it's not really tough. So yeah.
Thanks. Sarah, or is it Sarah?
It's Sarah. Fine.
It's Sarah.
For Hannah, yes. So I mean, Julia, I've kind of been part and watched this work as it's progressed, and thank you to you and your trauma champion colleagues, both locally and within Forth Valley, for really taking a grip of this. And I think the passion that you feel for it, we can all hear today, and I certainly hear echoed in relation to your colleague champions. So it's really great to see this work progressing, and I'm really pleased to see the progress being made on the strategic post. Just a couple of things from me and then a kind of question at the end. So although poverty doesn't sit as an ACE, I think we do know how much of a contributing factor that is to which kind of enhances the prevalence and longevity really of trauma. So I just think that's really a factor for us to consider once we have our new post in place when we're looking at policies. And also it's certainly a place of focus, I think, for trainers to really make sure people that we're training are thinking about the impact of poverty, because clearly we're all really concerned about the place that our families and our individuals are going over this year and future years. And I'll just finish up because of time, is really just to say we do need to make sure that the new post thinks about the future proofing of those policies, because we do only have the post for 2 years. So we're getting really smart, I think, about thinking about resilience, because we're very well aware that it's going to be unlikely we're going to either, well, who knows what the funding will look like going forward, but we'll want to make sure that we're thinking we've got this for 2 years, so how much can we do to maximise this? And maybe I'll not put this as a question, but maybe we'll just again put this down for further thought, is about how we're going to measure impact in terms of the training with our workforce. How do we know it is going to make a difference? And I think there's going to be some important points that are going to come from the workforce, notwithstanding the point that has been made by Roger in terms of the impact on themselves, and the comments that Councillor Hannah's made about her elected member colleagues, but also, I suppose, about, I think what we're going to hear a lot from people is time. Time is really what's required to make people feel really valued and heard and respected. And time is in very short demand, supply. It's in great demand and short supply. So I think we really need to hear that, if that's what's being said, and hear whatever's been said. But there are, to get environments right needs funding. It's rarely something that can be done without some financial support to improve the look of some of our areas. And when I go out to see some of our workspaces, those front reception areas could do with a lot of thought through that trauma-informed lens. So thank you for letting me speak there, Councillor Hannah, and thanks, Julia, for the report and your presentation.
And maybe just say that those two bits that you talked about at the end there go together. The measuring the impact and the question of funding, because if there's any chance whatsoever of getting any kind of continued funding, you have to have the evidence of the impact and be saying these are the things we would use funding for. So I don't know whether you've got anything to say about that, Julia, or if you want to take that and bring back some more detail on impact measuring
I
lead.
think that is the so I guess that's the sort of, and I spoke a little bit about this at the CPP, but that's kind of the support behind it is we do lots of this work, but actually if it's punted up and nothing's kind of supported financially, and there's not that really senior leadership behind it, and I think there has been really good support, but I guess financially that it would have an impact, and that's a consideration. So having that it's about the art of the possible a little bit, and doing what you can with what you've got. And for me, absolutely, environment stuff's really important. But the key bit is the relationships that people have with the people that come into our buildings and come into our services, and feeling like there is value and they're person-centred and they're dealt with a way that actually matters to them, and not having to fit into a system. My experience has been that that's the bit that matters, and so there's bits that can be done within that, but yeah, there absolutely will be a bit of a fallout in terms of if the environment is really terrible and actually people don't come because it's so difficult to come into a building or come into the offices because it smells different, and I think when you talk about housing is a really good example, because within our housing establishments, they can be really difficult environments to be in. It can be quite challenging to make that feel homely and feel like the welcoming, I guess, in a way that would match everybody. But there's definitely things that can be done for people, and I think it's about critically asking those questions. And yeah, but you're right, and I think the measuring impact, I think that's really key actually, and something that we've had some conversation about to date. How are we going to know that this feels better? I mean, undoubtedly, if you're shifting culture in a way that feels more open and transparent and person-centred, without a doubt, that should feel better. But we want to be smart about that and pull a bit of measure round about it as well. So I think that's a really good point, Sarah.
I'm conscious that that's what right. Can I just double check, David? What time do we have to close the meeting? Is there a deadline or?
Well, I think the meeting's scheduled until 11:30.
Right.
Usually.
Just that interesting though this is, we need to move on because there are other important reports here as well. But thank you very much, Julie. I think that's very useful, and I look forward to further reports and further briefings. Okay, the next report would be Suzanne Thompson, the overview of local too many overs.
It's a bit of a mouthful.
Local oversight.
Thank you, Councillor Hannah. I'll keep it brief in terms of the times. So this report's a standing agenda item for committee, and it provides an overview of a range of committees and groups that are in place that are relevant to the Health and Social Care Partnership in this committee. We've also included in the report information on the newly established Health and Social Care Partnership Clinical and Care Governance Management Group, and more detail of that's in the governance paper that's later on in the agenda. And in future, an update of the work of this group will be included in future reports. So the report follows the standard format that we've developed for committee, and it provides updates on the Public Protection Chief Officers Group. Probably most notably was the recent presentations that groups had relating to drug-related deaths and suicide prevention work, as well as gender-based violence, the draft strategy that's been developed. We've included an update on the Adult Protection Committee, and that mainly just summarises the newly published national guidance that's been issued, and that's been considered by the committee and taken forward. There was 4 sort of national publications guidance around those areas. The Alcohol and Drug Partnership work has been included as well, and that provides an update on the MAT standards, as Martin sort of previously discussed earlier in the agenda, the requirements around the annual report, and the new requirement on EDPs to complete a self-assessment, and that work's been underway. It came in with quite tight timescales, but it's well underway. And we've also included some information around the drug-related deaths national publications. We'll just note that the further updates would come back to this committee on those areas. The NHS Forth Valley Clinical Care Governance Committee and Working Group arrangements are set out at section 7, and that notes the business that were considered by both those groups. And we've provided an update in section 8 on the care home assurance work and the clinical and professional oversight group. for care at home and community health is updated at section 9. Many of the leads of these groups are here and can support any questions you may have, but in conclusion, the committee is asked to consider and comment on the report. Thank you.
Okay, does anybody have any questions, first of all, or comments? No. I had a couple of questions. He said that at 4.7, he said despite various demands, the team has succeeded in addressing the backlog of unallocated cases. Is that ongoing and still up to date, I suppose is the question. Are you still with us, Suzanne?
Yes, sorry. This relates to child protection, sorry, yes. And I wonder if Sarah looks like she wants to come in here.
And that one, Sarah, yeah, that'd be ideal.
Yes. Councillor Hannah, I think you might be referencing the initial response team. We had a presentation of the progress of the pilot initial children, families, social work initial response team at the most recent Public Protection Chief Officers group. So there is actually quite a full report coming to the Education, Children and Young People Executive. But yes, happy to say that the pilot team, who's now around a year in on a 22-month pilot, has made a really significant difference to unallocated cases. So that was one of the primary reasons why we put the pilot together. But an important part of it, and we've had really good success from the team in terms of resolving that issue, very timely responses to those initial referrals, so that first contact with children and family social work, much better response times, assessment for all children, but there is still an issue from any cases that then need to be handed over to localities. There is still a challenge there around capacity, but that's because we're seeing so much increasing demand. So hopefully that answers your question.
Yeah, that does. Thank you very much, and I'll pick up more when it comes to the education exec. The next bit was 5.4, the Esp Code of Practice. Now you say that it has been updated, but I tried to access it online, and it's still the 2014 version that's up there. I don't know if there's, if I'm just being too impatient.
Sorry, Councillor Hannah, I'm not sure if there's been a rollout of the new Code of Practice, but just starting this week, as far as I'm aware. So it might be that you've just been a little early.
I would be behind. Okay, anybody got any other questions that they want to ask or comments? Listening for my wee notes. Yeah, there was one other bit, which is 9.1, talking about the incidence of outbreaks of COVID in care homes. Since writing the report, are we still keeping on top of that? Saying that the incidence is a lot less than it was. I'm hoping that that's still the case.
Councillor Hannah, I can come in on that one.
Yep,
if that would help. So we've got a weekly cross-system assurance group in place, and we've through our clinical and our social work chart teams, we are supporting our care homes and also making sure that we're continuing to review and take those assurance. So the number of outbreaks has reduced significantly, and I think most importantly, the impact on the people that get COVID is much less severe. Yeah. So that is the current situation. We did see a slight increase in the number of outbreaks a few weeks ago, but we're back down again. So we do monitor that very closely, and we meet as a cross-system group on a weekly basis.
Excellent, thank you. I don't have any other questions or comments, so if nobody else does either, we'll move on to item 7 on the agenda, which is the overview inspections report, and that's again you, Suzanne, I think.
Yes, thank you, Councillor Hannah. The report provides an overview of inspection reports of health and social care partnership services that have been published since the last report to committee. Where there are significant issues arising from these reports, more detail will be provided, and committee members can also highlight if they would want more detailed consideration of any inspection report brought forward to another meeting. The table at 4.1 notes that we had 6 unannounced inspections that were carried out by the Care Inspectorate. 3 of these relate to our in-house care and support at home services, and 3 are in relation to our residential care homes. Our care and support at home services were previously under one registration for the whole of Falkirk area, and in 2019 they were registered under our 3 localities, and that was done primarily to support more effective and integrated working at a locality level. So the Care Inspectorate assessed under 2 quality indicators for our care and support at home services, and assessed all 3 services as good, and further breakdown is included within the report of each of those locality inspections. The report also notes inspection findings of Cunningham House Care Home, and that was against 2 quality indicators, and they were evaluated as very good. For Grahamston House, again, they were evaluated as very good against 2 quality indicators and good against a 3rd indicator. And for Thornton Gardens, they were assessed as good against 2 quality indicators. And just to note that all reports are published on the Care Inspectorate website. The report also notes the Healthcare Improvement Scotland unannounced inspection of Forth Valley Royal Hospital, and that covered a range of areas, and that's set out at 4.17 and 4.18 and 18 in terms of the report about the areas they looked at. And again, the inspection report highlighted a number of areas of good practice as well as areas for improvement, and an action plan has been developed to ensure these areas are implemented. Just to conclude that all action plans developed in respect to inspection findings are monitored by the relevant lead service manager or manager for those areas, and also the Health and Social Care Partnership senior leadership team. So in conclusion, committee is asked to consider and comment on the report. Thank you.
Okay, does anyone have any questions or comments? Pleased to note that all of the inspections showed it as good or very good, obviously, and for unannounced inspections that's particularly good. So that pleases me a lot. Anybody got any other comments or questions? No. Okay, we'll move on then to the health and social, the item 8, health and social care complaints and feedback performance report, and I think that's, there are several authors of that. Who's wanting to speak to that one?
Chair, it's Gordon Mckenzie from the Falkirk Health and Social Care Partnership. I'll start off if that's okay with Amanda.
Absolutely, Gordon.
Thank you. You may have noticed I popped in and out of the meeting because I'm trying to multitask here. For those who aren't familiar with this report, it's split into 2. There's the social work part, and there's the NHS part, as it were. About 18 months ago, we looked at the figures for the complaints across the social work part of the partnership, and performance wasn't where we wanted it to be or needed it to be. We did quite an intensive piece of work with frontline managers over a number of months, and we saw a steady improvement, a significant improvement indeed, over that period, up to beyond 80% response rates within time frame for the stage 1 reports. There's a lot of variability in the stage 2 reports, complaint reports timescales, because the numbers are so small. You get one, they're quite complex as well. So one goes out of date and you're either 33% or 50% down on target. But the stage 1s are a larger group, and we had quite a bit of success with that. So over the previous 12 months, our performance has significantly improved, but that doesn't give the full picture. Over the last 3 quarters, there's been a declining picture. It would appear that we need to re-energise that piece of work that we did with frontline workers, frontline managers, and get that performance level up again. So, as you'll see from the data in the report, the picture is better in the last 12 months than it was in the preceding 12 months. But within that, we recognise that there is a need to give fresh impetus to that. For everybody, it's been a really busy time. I don't think there's any particular reason other than workload that there has been a decline in that. But we'll go back over it with the frontline managers. Happy to answer any questions around the detail of the social work part of the report. Thank you.
Can I just ask a question, because it just brings to mind for me. As a counsellor, I have complaints brought to me. So far, I simply contact the relevant person and try and chase it up. I don't formally say this is a complaint. Would that actually be treated as a complaint through the complaints procedure, or is that just treated as an inquiry and not counted through the complaints procedure?
To be honest, I think we could be a lot better at being consistent about that. We certainly do get some complaints that have come through counsellors that are logged as complaints, but equally some do come to us and they are dealt with there and then as inquiries, and we get it done. And where possible, we're obviously not wanting to put people through a complaints procedure if that's not appropriate. So if we can deal with the inquiry, as it were, and get it resolved, then we would like to do that. And even within the complaints process, there is a mechanism where we resolve it as quickly as possible. So I'm afraid I can't give you a definitive yes or no. I think that's probably as much as I can say about that just now.
It's just, I think it's worth thinking about, not because I want to increase the number of complaints in your reports, but complaints is how we learn.
Yes.
It's something has gone wrong, and we look into it in detail. That's how we learn how to improve the service. I don't see complaints as being a bad thing. I think there are some people within services who think, oh, I don't want complaints. I think if there are no complaints, then there's something wrong. You're doing something to prevent it.
Yeah.
Anyway,
and sorry, Stuart. We fully agree with that comment, and we need to be doing analysis of where the complaints are coming from and what overall where the complaints are coming from and what they're about, as well as looking at the specific individual complaints in order to learn.
Yeah. Sorry, was somebody going to talk about the NHS bit about it, or does anybody have more to say on
No, sorry.
No? Okay.
Hi everyone, my name's Mandy. I'm the Patient Relations Lead for Forth Valley. I'm just going to talk about the NHS side of business. So if I draw your attention to page 51 of the report 4.1, between April and June of this year, the partnerships, there's been 4 complaints relating to the delegated functions. 2 of those were dealt with at stage 1 and got a 100% performance so far. 2 were dealt with at stage 2 with a 50% performance, which gives you its current end of year at 75%. There were about 4 departments in the delegated functions, and outcome wise, 2 of the stage 1s were not upheld. 1 was upheld, 1 was fully upheld, but both stage 2 complaints were not upheld. And there's currently no cases sitting at the Ombudsman's office so far this year with regards to the delegated departments. Thank you.
Thank you, Margot. Does anybody have any comments or questions?
I think Margot has her hand up, Councillor Hannah.
Yeah. You still have your hand up, Margot. Do you want to say more? Nope. Hand's disappeared.
Margot, you're on mute.
Oh, so is Margot.
It was just on mute, I think.
Right. Are you still wanting to speak, Margot? Yes, you're on mute, yeah, still.
Right. Just to say, is care opinion involved at all in the process for social work? Because I know, having received the report on NHS, the very valuable function it serves in giving people answers without having to always recourse to complaints. Just wondered if social work used that as well.
Gordon, are you able to answer that?
I can come in
Sorry,
to
yeah,
that.
Suzanne, okay.
We brought a paper to, I think, the clinical care governance meeting last time round about our lived experience involvement work that we were doing, and one of those areas of work was to look at care opinion in terms of the sort of health, the wider health and social care partnership, because I know it's used quite widely in terms of the healthcare setting. So that work's continuing, and we can put it on the action log, and I can get an update if that would be helpful for the next meeting.
Thank you.
Be good, thank you. Is that enough for you, Margot?
Thank you.
Happy with that? Yeah. Okay, if nobody has any other questions or comments, then we'll move on to agenda item 9, which is Jonathan. Is Jonathan with us?
Yes, I am. Thank you.
Yes.
Thank you.
Okay.
Okay, thank you. Good morning, everyone. Yeah, my name's Jonathan Hoard. I'm Infection Control Manager for Forth Valley. Just quickly go through the quarterly report and firstly talk about just briefly on the COVID situation we have. Within this last quarter, we did see quite a steep rise in our COVID numbers within the inpatient setting. This is to do with one of the Omicron subvariants, and you can see in the graph on page 59 that you can see that some of the bigger peaks were associated with the different strains that were circulating around Forth Valley. So we did have this peak at the end of June, fortunately, up to a maximum of around about 75 inpatients, which is quite a bit considering what we had in the past. So unfortunately, numbers are falling in the right direction. We have around about just over 30 patients within our hospital settings currently. So fortunately, I mean, over this last quarter, there were no incidents or outbreaks within Falkirk or Bowness hospitals, which is good. Just further to give some reassurance about the hospital onset COVIDs that we have, we submit data based on hospital admission times to our High Scotland, which is, like say, like a governing body as nationally, and they publish a weekly report on our hospital onset COVID. So these are the ones that patients have actually acquired or believed to be acquired COVID within the hospital settings, and we're sitting about 17.8%, which is far lower than the national average of 24.7%. So we're sitting quite comfortably. We always have sat much lower than the national average, and in terms of the size of boards, we're sitting at one of the lowest. There are boards with lower percentages, but these are the smaller boards, either the Highlands or Islands or like Dumfries and Galloway and things like that. They're just the smaller boards. So moving on to our annual operating plan targets, and I'll go into a little bit of detail on the individual cases for our E. coli bacteremias. Well, before I say that, the target that was initially set for March 2022 has now been changed to March 2023. The Chief Nursing Officer for Scotland made the decision that, given the ongoing resource and pandemic pressures of the last couple of years, it was more sensible to delay the target until next March. For our E. coli bacteremia targets, we are still sitting very high. We're probably unlikely to meet that target for March 2023. It's always based on the last 12 monthly mean, and as you can see in the graph there, we're sitting way above our trajectory line. So I suspect, although efforts are made, and I'll go into a little bit more detail when we go into the breakdowns of these graphs, that we're unlikely to meet that target. But again, I'll go into a little bit more detail later on in the report. For our Staph aureus bacteremia targets, we did have a peak in June, or May, sorry, but now we have returned back to normal and we're sitting underneath the trajectory line. As applies to the Clostridium difficile rates as well, our numbers have fallen, and we're quite confident that we will achieve that target in March 2023. Okay, so moving on to slightly a bit of the details about each one of these. Staph aureus bacteremias. So just to give you some background on that, I mean, I appreciate my report's quite technical. So for those who don't understand, Staph aureus is a bacteria that's is present on the skin. All of us will have Staph aureus on our skin, and it's probably responsible for about 80% of all types of wound infections. So if you cut your finger and it goes a little bit pussy, chances are it's just a Staph aureus that's from your own skin that's causing that infection. The challenges are is when those bacteria actually escape and break out into the bloodstream and cause systemic problems. So that's when you get the temperatures and more so worse can lead to ultimately death as well. So these are the things that we monitor because Staph aureus bacteremia many years ago was considered the most frequently encountered organism from a blood culture. So when people have thought that they're septic, some blood's taken off the patient and put into a culture bottle, and then they'll see if there's any bacteria within that blood. So that's how we identify bacteremias within the microbiology lab. So this is why we're looking at Staph aureus bacteremias. So for us, our numbers for this quarter have gone up a little bit, but that was to do with that increase we had in May. Again, our hospital numbers remain very low. We had 4 reported for the entire quarter last year. A predominant challenge is within the healthcare. So it's only by definition of when the blood culture was taken, and these are the ones that infections have acquired out in the community. So they're quite challenging to actually put interventions in place to reduce these infections. Fortunately for in Falkirk community and Bowness community hospitals, there were no reported Staph aureus bacteremias. For our device-associated bacteremias, again, this is not part of the AOP target. This is something that's local to Forth Valley Royal, Forth Valley as a whole, because we felt that some of the targets are a bit limiting because we're chasing specific organisms, but we're not looking at specific infection types. So we decided to look at device-associated bacteremia. So anyone with a device in situ, a urinary catheter, a cannula, and any organism that is associated with that infection, we will review it and we report it. So this is why we're doing it. We're the only board in Scotland that does this, but feel that it's important, being taken from a patient-centered point of view, that this is beneficial to the patients in Forth Valley. So this is why we're doing it. So in terms of our numbers, the numbers remain very steady. Again, our hospital-acquired infections remain very low and very consistent. Again, our predominant ones are those from healthcare, and these are from probably like urinary catheters and other lines, Hickman lines, for people who are on chemotherapy and the infections developed out with the hospital setting. For Falkirk and Bowness hospitals, there were no reported device-associated bacteremias, which is good. Our E. coli bacteremias, as I said, this is the one we've been challenged about achieving our AOP target, and we've seen an increase in our numbers. Our hospital-acquired ones remain consistent, and again, as you can see in the table, that the predominant challenges are around the healthcare ones. We have looked at this quite extensively over the last 18 months or so. We've looked at predominantly the causes are biliary sepsis, so that's infections of the gallbladder and the bile duct that's leading from the gallbladder, urinary tract infections, and catheter associated urinary tract infections. So we've done a deep dive into the biliary sepsis. There's not a lot of interventions we can do. We know 50% of these patients have had previous biliary problems in the past, or previous gallstones, and they have a tendency sometimes to be conservatively managed, so you don't have to necessarily have some surgical interventions on these, but sometimes the gallstones then block the gallbladder, the bile duct, and that causes inflammation and then infection. So, and urinary tract infections, again, these are ones that are uncomplicated urinary tract infections, but then that progress and turn into urosepsis. Urinary catheters, again, is predominantly from the healthcare source. We have done a deep dive very recently on those sources, and we found that the systems that are in place currently out in the community are very robust, and we could see on our systems, we can see that when phone calls are made from the patients to district nursing about obviously issues with their catheter, the district nurse goes attends that same day, and you can see the story between that point of call with the district nurse into the hospital admission. And, and there's been various reasons, but nothing to do with the lack of care or anything that we could identify through our investigations, which is encouraging. So just to give you a quick brief background about the E. coli ones and the challenges that we're facing. So fortunately for Falkirk and Bowness Community Hospitals, we had no reported bacteremias from this quarter. Clostridioides difficile infections, again, and numbers went up just a little bit because we had an unexpected increase in June. Fortunately, numbers have fallen back to normal levels now. So, and again, our hospital numbers remain very low. We only had 2 reported in this quarter. Again, Falkirk and Bowness, both, there were no reported cases for this quarter. Moving on to the estate and cleaning compliance, we've had a recent, only since publication of this report. Oh, no, I'm getting muddled up with another hospital. It's not within this area, so I beg your pardon. So again, Falkirk remain in amber at 88% and Bowness at 95%, with a board-wide totals of 94%. So, Falkirk has improved, but again, we should have our next report. I have the most up-to-date data on that. And lastly, just going on to incidents and outbreaks, and again, there were no outbreaks related to COVID or any other infection in Bowness or Falkirk Community Hospitals. And I'd be happy to take any questions. Thank you.
Okay, could I just ask a little bit clarification what you mean by estates compliance?
Right. On what usually happens is our domestic service team that do this audit. So it's a national audit that's submitted, and the domestic services teams monitor the system, chooses various areas that they have to audit. And what they look at is look at the cleanliness and also look at the estates side of things, and it's all based around the ability of being able to be cleaned effectively. So if there's like damage to a skirting board and there's wood exposed and so on, and things aren't painted or chipped, then obviously you can't clean them effectively as it would be if it was a nice clean surface. So it's our domestic team that report on this, and all that data then is submitted to a group that oversees all the estates work. There's the estates compliance group that monitors this as well. So that's fed back to them for so they can remedy any of the problems. The limitations of this of the audit is you can have multiple very minor things, and that adds up into a score, and that will create a lower scoring. So just give you an example: if there was some staining to some bathroom sealant, around a sink in a shower area of a bathroom, something like that, that would probably be marked down, saying, so it doesn't show an indication of the severity of this state. It's just showing that there are perhaps lots of little things that could be rectified, but are not in terms of anything particularly severe. But like I said, our numbers are very, still very high, just shy of the 90% mark. So it's nothing that I think we have been regarded as being quite honest in our reporting compared to other hospitals, because we've heard other reports from other boards saying there is no way we can get 95% in our estates in some of our hospitals, because just by the very nature of the age of the hospital and things like that. So I think we are particularly honest with our reporting, which is a good thing, I think. So yeah. I hope that answers your question.
Yes, that's fine, thank you. I've got Margot, then Elaine.
Right. Thank you. Would you say that the capacity issues in the summer and, putting an extra bed in 4-bedded units did affect the increase in infections, particularly Staph aureus, I would think.
No. What we found, even at the height of COVID, so at the worst was in a couple of years ago now, when we had over just shy of 200 inpatients with COVID, and we found our Staph aureus bacteremias, our device-associated bacteremias, and Anaclostridium difficile infections all remained very low, which was surprising. Other hospitals didn't see this. They found an increase in Staph aureus bacteremias, but we did not see any increase at all, which is so encouraging that the ward staff are still maintaining levels of that degree of safety. Even these unprecedented circumstances that we're facing at the moment, with these capacity issues. So yeah, no indication, which is really good.
It's very encouraging. Thank you.
Thank you, Margot. And Elaine?
Thank you, Councillor Hannah. My first point is around your question around the community hospitals, Councillor Hannah, and the kind of compliance. I just wanted to provide some assurance around that as a management team we work very closely with our estate colleagues, and when there is a dip in performance, we're sitting at amber, but what happens is some actions are taken to remediate things, but it's an older property, so when you fix one thing, another thing goes, so it's not as if we're not paying attention to the issues, but because it's older buildings, it's harder to maintain some things, and the patients in these wards, it's their home, and they're out and about and up and about, and that in itself causes some damage to the property sometimes. So when our colleagues are coming in assessing the areas, sometimes it's just an ongoing issue of small estate things that cause a dip in compliance. My second point is for Jonathan. Jonathan, thanks very much for that super report. Just a question about the E. coli bacteremia. I note that there's significant work being done around urinary catheter infections. Is there other work going to be taking place with some of the other work streams that cause the bacteremias and the sepsis?
We've done a lot of look back, like I said, in biliary sepsis, urinary catheters now looked at. What's left with us now is the likes of lower urinary tract infections, which, those acquired in the community is very difficult. We know E. coli bacteremia rates go up in the warmer months. So when you have a hot weather, then we see rates go up. So it is quite seasonal. Nationally, it is recognised that it's out with the gift of infection control teams to sort of make sure people are hydrated effectively out in the community. I know from firsthand, my father used to just drink his couple of glasses of water every day, come rain or shine, and that was it. So when you get the hot weather, but we know then, if people become dehydrated, especially people who are immobile, then they're more likely to have infections and so on. And that's, it's anecdotal at the moment, because I haven't looked too much into it, looking at the hydration status, and it's sometimes very difficult to actually do that without pulling each note, getting the notes out. But there is something that work, but they are recognizing now it is more of a national thing. So they are doing things like hydration campaigns, and I think that's on the cards. They did have the Scottish Urinary Tract Infection Network a number of years ago, but they are looking at this and maybe trying to broaden their approach in terms of interventions like from public health and things like that, and health promotion. And so yes, we are aware, but there is a limitation of what we can do within the hospital. It's within our gift. It's easy to, and that's why our numbers, I believe, remain very, very low. We're always going to get infections from urinary catheters and things like that. E. coli is the most prolific organism within the gut system, and it's the most common organism that causes urinary tract infections. So you're going to get infections come what may anyway, and regardless of how, we're in this modern age and all that, at the end of the day, bacteria still get us, and cause infections and so on. So yes, so nationally they are aware of it, and so we are trying to do our best in terms of trying to identify ways of doing it, but they're beginning to recognize the challenges, just leaving it for infection control teams to sort of reduce.
I'm really pleased to hear that. The reason I brought it up is from that community focus that actually it brings people to hospital. It brings our older members of the community to hospital because they've significant urine infections that actually debilitate them and almost accelerate frailty. So it's actually quite a significant problem, and quite a lot of our admissions at the front door. Further down the line, it's identified that it's a urine infection.
Yes.
So it's something that I'm really interested in, and if there was any kind of national work, Jonathan, I would love to be kind of considered to be a part of that. Thanks.
Will do.
Yes, I can speak from personal experience of elderly relatives. I'm very familiar with that downward spiral that occurs, and the hydration problem is a big one. Welcome to those who have joined us during the course of that. Any other questions for Jonathan, comments, or have we finished with that item? Okay, thank you very much, Jonathan. That was a very good detailed report, and thank you for your explanations, which clarified, which meant I didn't have to ask questions. Now, the next report, item 10, is risk management update. Now, there's a number of authors for this as well. Are you picking it up, Suzanne? Yes.
Yes, thank you. And Sarah arrived with impeccable timing there in terms of was one of the authors of the report to answer more of the technical questions. So Sarah Mckenzie is our corporate risk manager in NHS Forth Valley and has been supporting the IJB around a range of work. But in terms of this paper, the report presented to you today summarises ongoing risk management discussions, and that's to align the relevant clinical and care governance risks to the IJB strategic risk register, and to sort of do some work around how we report progress against that to committee. It also describes in the report the work done by the Health and Social Care Partnership with support from our partners, risk management leads, to review the register. So at section 4.1 to 4.4 of the report, we're providing an update on the work being done by the Public Protection Chief Officer Group to review their risk register. And this is done every 6 months, with the next update due in September. The COG subcommittee and groups review their operational risk registers more frequently, and some at least quarterly. And the report also notes some examples of how this work feeds into the other reporting structures that are in place, such as the Health and Social Care Partnership Senior Leadership Team, our Adult Protection Committee, our Chief Social Work Officer annual report, for example. And this structure that's been put in place should ensure that we have an integrated approach to risk assurance reporting for all partners. At section 4.7, we're summarising the internal audit review of the IJB risk management arrangements, and that was reported to the IJB Audit Committee in December 21. The corporate risk managers from NHS Forth Valley has used the findings of this audit to inform the draft IJB risk management strategy. And this work has been led by the Chief Finance Officer, and an update is included at 4.10 to 4.12 of the report. So in conclusion, the report notes the ongoing work with clinical care governance and risk management leads to align the relevant risks in the strategic risk register to the work of the committee, and to consider how assurance will be provided. And the committee is asked to consider and comment on the report, and we're all happy to take any questions. Thank you.
Okay, thank you very much, Suzanne. So you're saying that the updates will be considered by the Chief Officers Group in September. Will that then come to the IJB, the following IJB?
We have an update coming to the IJB next week. The papers should just be getting issued around the strategic risk register, and then there'll be further work that filters through Audit Committee and then IJB in terms of the reporting lines. But this work has been bringing together a range of reporting requirements and just trying to make sense of that landscape.
Still trying to get around what comes here and what goes to the IJB. Okay,
I think that's what that work is also trying to sort of unpick as well. And in terms of how we sort of streamline that process, and we sort of minimise duplication as well. So I think this has been a really helpful piece of work to try and look at that and get some consistency around it.
Okay, thank you. Anybody else got any questions or comments? No? Okay, well, thank you very much, Suzanne. And unless Sarah's got, no, not it was Sarah, was it? Sarah or Sarah had anything to add? No.
I don't have anything to add, Councillor Hannah, thank you.
Okay, thank you very much. Then that report's been noted then. Next on the agenda is item 11, the care home annual report. And I think, Ellen, are you going to read on that one?
Thank you, Chair. Yes, so my name is Ellen Hudson, Deputy Nurse Director, and I'm actually doing this on behalf of a wider Oversight Assurance group as well, in terms of giving you a summary of our care home annual report 2020 to 21. So this all came about because obviously as a result of the COVID-19 pandemic, in terms of the impact on a number of particular areas, particularly the care home sector, Scottish Government had requested that NHS boards and health and social care partnerships assumed additional responsibilities, and this was really important in terms of ensuring standards were in place and that we could assure the safe care and well-being of residents and staff within our care homes across Forth Valley. So initially this resulted in a number of new roles quickly having to be developed and new processes embedded in terms of what our oversight arrangements needed to be. But committees should be assured that you have been getting regular reports to this committee through the care home assurance work within the overview local oversight arrangements report that you get on a regular basis. And in addition, updates have been provided in the Chief Officer's report to the Integrated Joint Board as well. By way of background, I think this was unprecedented. We had never been in this position before, and we had to really mobilise very, very quickly, and it was uncharted territory. So we worked very quickly across the health and social care landscape and system, across the whole of our health and care system, and the leadership came together very, 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 very quickly. As you will see, in terms of the initial summary at the beginning of the report, and the foreword is by Angela Wallace, who was our then Executive Nurse Director, and both our Chief Officer for Falkirk Health and Social Care Partnership and Anne Margaret Black for Clinic Manager and Stirling Health and Social Care Partnership. So we very, very quickly had to come together also with key colleagues within public health, our GP colleagues, and all our systems coming together. What could be mobilised in terms of going in and supporting the health and well-being of residents within care homes. So this annual report shows the journey that we have been on over this last year, and very much how we developed a kind of shared and strategic response to supporting care homes. And I have to say that it's a lot of colleagues who are on this meeting today have been joined me on this journey as well. And what's really, really important is the lessons learned along the way in terms of how we've constantly improved what we've been doing. And so this production of this report has actually been an opportunity for us to review what's currently in place, what has worked well, but also to continue to identify if there's any gaps and where improvements are required as well. And we've been very fortunate. We've been able to influence and share at a strategic level as well in terms of what we've been doing, because there was weekly reports had to go into Scottish Government, and that still continues, that we do that in terms of what our oversight arrangements for our care homes across the whole of the system. So as I said, there was a number of dedicated teams that were rapidly put in place, and that was teams to ensure support care assurance, so that we're doing the right thing and we could mobilise people very, very quickly. Teams as well to look at what the clinical care was required and whether in relation to safe staffing as well, that the staffing was adequate as well, because you face often with the situation, not only did you maybe have residents that were COVID positive, but you also had a workforce who became COVID positive as well. So that meant ensuring that you had a continuous supply of workforce to support as well. In terms of our colleagues within health and social care partnerships, social care chart teams were mobilised as well in terms of that support of our partners within the care homes as well. Very much we were working in partnership with our care home colleagues. Very much this was their areas of expertise, and we were only supporting them and enhancing ways of working, things that they needed to do as well, because it was unprecedented, some of the new initiatives and things that they had to put in place in terms of ensuring that if a home was an outbreak, there was PPE stations set up, making sure there was compliance with infection control standards, some of these things that Jonathan's already been reporting on as well, and making sure that all attempts were made to make sure that our residents had access to care and support and clinical interventions as well. And there was another particular team that was dedicated to supporting any residents within care homes that were COVID positive, and that was our clinical chart team, and that was a team that was mobilised with GPs, specialists, palliative care nurses and advanced nurse practitioners, and they provided that clinical support and interventions as well, which is really, really important. So the key issues that I would like to draw your attention to in terms of the report was the range of new roles that we've had to develop as well. And obviously there was government funding that came in, a range of these different support, but that funding is only until March 2023. So it'll be really important to see what goes on in relation to after that period. Really to note the collaborative multi-agency relationships that were developed successfully with teams, and the learning that went across all teams and all the roles, and that understanding that at the heart of it we had this safe care and the well-being of residents at the utmost of importance for us all. There was a really strong leadership and governance framework that we developed from the outset, and I think that has been a blueprint, I have to say, in terms of nationally. We fed that in and it has been adopted at national level. There was an oversight government group as well that we fed into, and they were looking for examples of best practice, and ours was became a bit of a blueprint for other boards across Scotland as well. But we don't want to lose the momentum. There's lots of lessons learned, and we're now about to be entering into another winter period. So it's about how we build on our successes, but also what we have actually achieved is embedding within our existing systems and processes really good ways of working that are now become common practice, which I think is actually a real true success in terms of we kind of forget the journey that we were on. We were having daily meetings to discuss care homes and the status in care homes up until a few months ago, and now because of the effectiveness of those systems and processes and that are all embedded, we can very, very quickly escalate any concerns around resident staffing or any concerns with the care homes through our due processes can be escalated to the appropriate bodies so that action can be taken as required. And very often it's just local resolution to particular issues as well. And if there is anything of significance, then we have got our weekly oversight governance group, our care home assurance group, and we are cited on anything that either has to be escalated to our chief executives within both the boards and the councils, and as well as nationally as well. And we continue with our weekly report into government in terms of the status of our report. So I think this, and another thing I'd like to share a piece of good news as well. And in October 2021, the multi-agency Forth Valley Care Home Care Assurance team was actually selected as a finalist in the Integrated Care Awards category in the Scottish Health Awards 2021 in association with the Daily Record and Scottish Government. And the judging panel noted the quality and strength of our nomination, and Forth Valley team finished in the top 3 nationally, which is absolutely excellent news as well. But another a really important framework and that will guide our practice in terms of going forward in terms of respective care homes was in the 29th of June this year. The Scottish Government published a healthcare framework for adults living in care homes called My Health, My Care and My Home. And this framework it provides key information and assurance and direction for all those involved in providing care and support, health and care to care homes. And this is really important guidance, and it has been developed around a number of themes. And actually what we are in the process of doing under the auspices of the Care Home Oversight Assurance Group is actually mapping where we are in relation as a health and care system to those recommendations, and that will identify for us in terms of any key priorities or where there's any particular gaps and areas that we want to take forward going forward. And I'd imagine that that work will also come back at a later point to this committee. I think it's really important that it does that in terms of seeing what our what we're going to take forward as a priority in terms of making any improvements that are going to support our residents in care homes as well. So as I said, a number of NHS boards and integrated joint boards in Scotland are looking to have teams similar to the ones that we've set up going forward, and our work continues. It doesn't stop in terms of supporting care homes in these unprecedented times and being a responsive system to in terms of whatever's emerging as well. And we continue to operate a joint approach of assurance, mutual aid and collaboration, and I think that's really important. So I'm really delighted on behalf of everyone to present this annual report to the committee, and happy to take any questions as well. Thank you.
Thank you, Ellen. First and foremost, I would congratulate the team on the work that they've done and the awards. That's obviously a positive. Couple of issues that spring to mind. You said that the funding comes to an end in March 2023, and that's not very far away. Have we got any inkling of any kind of continuation? Because one would hope that the evidence of the benefits of the work will have impressed those who are in charge of funding.
Yeah. So that funding was specifically related to the responsibilities that were given to every single executive nurse director in a board in Scotland. They were given that responsibility for the assurance of safe care and staffing in care homes across Scotland. So that funding is related to the developing a number of those roles. So as we talked about, the outreach team and which supports staffing, and the care assurance team as well. We also created a lead nursing post for care homes too, with some of that funding, and then it supported some of the elements of the clinical chart team, and it supported augmenting some of the infection control teams' input specifically to care homes as well. We've got all of that. So yes, absolutely. So government know that, and this is regularly getting fed in through the executive nurse directors meetings with CNOD to say what is the status of this going forward, so that boards can be prepared. As it's really interesting that framework document is that's about guidance and it's not mandated, and there is no funding behind that either, and it's recommended as improvements to ways of working, shall we call it, within systems and processes. I think this is what they will very much be looking to, but obviously that was pump primed funding that enabled us to set that up. So there would potentially be a gap if that was moved. But I think what we've been doing closely is looking at how do we work, especially with the colleagues that have set up the social care chart teams within the partnership colleagues. So I think that there is a potential for a gap, to be absolutely honest with you, Councillor, if that isn't forthcoming. But I suppose that's something that everybody is cited on. It is on the kind of risk register in terms of if that, what that mean in terms of implication. As you say, March is not that far away as well, but there is continuous lobbying done of the importance of these roles and posts in maintaining that, because that was never in the infrastructure, and then there was never a requirement to establish that before. And so it's a case of let's wait and see what happens.
Lobbying is always good, and if there's anything I can do from a political level, please let us know. But the next bit of the question is then kind of, have we got the capacity to put into place the improvements to the system that you've identified work in the event that there is no further funding, or will it just come to a dead stop?
And I think that's where it's really in the terms of the framework, the new framework, and if we map ourselves against that, because that's seen as being a kind of a blueprint for what would support ways of working and the condition how we do work together. So I think if we take forward some of those in gap areas and initiatives, I think that will go a long way towards supporting, making sure that we have got sustainable systems and processes and roles that have that within the remit to take that forward. And maybe, I don't know, Gail, is there anything you would like to contribute in respect of that?
Yeah, absolutely. So it is really important that we continue the good work around care homes. So one of the things that we are doing in Falkirk is looking at our structure that we have in place to make sure it is fit to deliver what we need for the future. So I think, as Ellen says, the mapping against the various recommendations within the report will be absolutely critical for us to undertake, to understand what capacity that's going to need. We obviously do have the social work chart team within the partnership, and we're looking to ensure that continues. It's fulfilling a really important role, and how we link that in with the clinical colleagues in the clinical chart team, and hopefully bring that. Ellen and I have had some early conversations about that vision to bring the social work and the clinical elements together to really support our care homes as much as we can. So I think Council Hannah will probably be bringing some more information on this to either committee or IJB in due course after we do the mapping work.
Thank you. Thank you very much. Thank you for being patient, Margot. You've had a wee while there. Would you like to come in now?
Well, first of all, just speaking as the service user representative, I just wanted to commend the report and all the work behind it, and to suggest that as it brings together a lot of the reports we've been having and the work that people are doing, each constituent partner could perhaps lobby for continuation and funding. I think it's good news about the chart care assurance selection, and I think it's even better news that we won in the top 3 for the Daily Record and Scottish Government Awards for integrated care. And I think our contribution obviously to My Health, My Care is fairly obvious. And I think all these things can be brought together in a big effort to assure people that this can go ahead, because it's of tremendous importance to patients and carers and those who are involved in end-of-life care. So I would just commend the whole thing, congratulate you, and thank you for making the presentation this morning, Ellen.
Thank you, Margot.
Thank you for that, Margot. Right. Any other questions? I just have one small point for future. I've looked at the feedback section of the report. It's good that that's in there. I would maybe have liked to see a little more feedback from staff and from residents in terms of, I mean, I recognise the difficulties in doing that, but I think it is important that that the staff in particular are able to make their comments and how they see it working, because sometimes staff, when there's somebody coming in from outside from an ivory tower, it's sometimes not seen as being positive, and it's good that you've got positive comments. So maybe if a little more of that would be good, or negative if they are negative.
No, thank you, and that was something we did recognise, and we wanted to get better at that and gather more, and we've got plans in place in relation to that. So that's good, because it should be that regular feedback loop, and we wanted to make it, rather than a once-off, have a regular way of staff feeding back to us and things like that as well. So we are looking at that as we speak.
Okay, thank you very much. If no one else has any further questions or comments, we go on to item 12, Clinical and Care Governance Committee Governance. What a title. Okay, Suzanne.
Thank you, Councillor Hannah. The report provides an update on the work being done to support the Clinical Care Governance Committee, and this is in relation to the chair arrangements, the membership and revised terms of reference, as well as the Clinical Care Governance Committee framework document. Section 3 provides some background on clinical care governance requirements and the establishment of this committee and its supporting documents. And these are designed to ensure the IJB, NHS Forth Valley and Falkirk Council on the quality and safety of the services that we deliver. Section 4 provides more detail on the work being done to date and that's in progress. The Clinical Care Governance Framework was approved originally in 2018, and in 2019 there were indications that new national guidance would be produced to ensure the effective, coherent and joined up clinical and care governance arrangements. This has been delayed, and as of writing the report, there was no further indication of timescales for its publication. But over the same time frame, we've had the pandemic. There have been several local and national changes, and we've integrated some of our services further. And we feel that that's indicated we need to now review the framework, and those reasons are set out in the report at 4.3. More recently, the Health and Social Care Partnership has established a clinical and care governance management group, and this group will support the continued development of the operational quality assurance systems, support our learning, monitor improvements and provide a forum to raise and discuss areas of good practice and development. And this is going to be based on the NHS Forth Valley structure and report around key metrics, and those are set out at 4.6. And the committee will be familiar with these metrics as these provided through the update on the Oversight report, which has been considered earlier in the agenda. The group will provide a committee with assurance of a robust system of clinical governance and risk management within our operational services, and the group will also review the framework, and this will be done in conjunction with the Chief Officer, our Chief Social Work Officer, our Director, Medical Director, Nurse Director and GP Lead. And it's proposed that the refreshed framework will be presented to a future committee for consideration and then to the IJB for approval. Lastly, the report provides an update on the work to review the terms of reference for this group. It's proposed that the proposed amendments are attached as track changes for ease. These will also be considered again once the framework has been reviewed. And the membership is also noted at 4.11 with the chair arrangements set out. So in conclusion, committee is asked to note the planned work to review the Clinical Care Governance Committee framework and to agree the chair arrangements, membership and revised terms of reference for IJB approval. Thank you and happy to take any questions.
Anyone have any questions or comments? Being new to this, I have some difficulty in sort of conceptualising what the previous system and the future system and differences. So I was hoping there would be others who would help there. In that case, it's going to come to the IJB anyway, so I'll get a second bite at the cherry.
I can certainly have a conversation with you if that would help as well, Councillor Hannah.
Just so I can get my head around it properly. Okay, if no one else has any questions or comments, we will go on to item 13, an overview of National Publications Act. I haven't had time to have a look at it, so I can't really make any comment. Does anyone want to highlight anything in particular? No?
The report's just an overview report of the publications that are relevant to the Health and Social Care Partnership and to this committee. So it's just summarising, 9 publications that have been issued over the period. And obviously in presenting this report to committee, it's recognised that national publications might need to be considered across a wide range of governance and leadership groups. Some of these are reported to the IJB and some, for example, to Audit Committee or other mechanisms. And clearly the committee want more information. You could highlight that and we can look at any further detail that you might need.
I have to be honest and say I didn't quite get to looking at them all, so I can't really raise any questions. But if that's everything for now, does anybody have any other business that we have that's pressing? There isn't any other business there on the agenda, but no. I'd like to say thank you very much, and that's really good. We've managed to do it all within time, which impresses me. So thank you all very much for your attendance and for your very useful reports and input. And I look forward to working with you over the coming months and years. Okay, thank you.
Thank you.